permission of the chair, Professor Asif Naqvi, and co-chairs, Professor Arif Nadeem and Zishan, I will need the permission to begin, sir. Thank you. I am very grateful to the audience for being here this afternoon after the Jummah break and after the PSIM well-being walk. And my talk is going to be about liver diseases and role of herbal product in causing liver protection. And to give you and share with you the evidence which we have. But before going on to that, I'll tell you how unfortunate are we in Pakistan because we are exposed to an array of liver diseases. And when a person comes with liver disease, all the person needs most of the time is reassurance. कई दफा लोग समझते हैं reassurance का मतलब ये है कि मरीज को कहें कि तुम्हें कुछ नहीं. That's not the reassurance. That is just brushing away what the fact is. Reassurance is to share with the patient his or her concerns and tell him or her that okay, this is a problem and it's going to get better with obviously change in the lifestyle and medication. Pakistan has staggering prevalence of hepatitis A. By the age of 10 years, 90% of our children, 90, test positive for anti-HIV IgG. But most of their infection is subclinical. Hepatitis A is responsible for most of the cases of acute viral hepatitis in children. And by the age of 14 years, 97% of people are positive for anti-HIV, but they don't remember ever having jaundice or hepatitis. And 5 to 6% of adults also get acute viral hepatitis because of hepatitis A virus. It's a rare cause of fulminant hepatic failure, but those who practice liver disease or hepatology, they see unfortunately a number of patients who will present with fulminant hepatic failure, and the mortality these days is a little less, but from a country where they have a regular liver transplant, they have found that hepatitis A is responsible for 10 to 26% of patients with fulminant hepatic failure who will eventually go on to need liver transplant. Out of a study of 2,735 confirmed cases of hepatitis A who developed fulminant hepatic failure, 36.7% died, and this, I can tell you, is a very low number for our country. This is not Pakistan. People in Pakistan, when they develop fulminant hepatic failure, more than 60 to 70% will die, and very fortunate few will have access to liver transplant. There are only 2 centers, one in Lahore and one in Gambat, in Sindh, which are offering liver transplant. And clinical picture of hepatitis A is a wide spectrum. Most of the time, no symptoms, but at the other end is fulminant hepatic failure. Come to hepatitis E, which is a common cause of hepatitis in adults. 10% of all adult acute viral hepatitis is hepatitis E. It is associated with very high mortality in the 3rd trimester of pregnancy, which reaches up to 35 to 40%. People think that those patients, the pregnant ladies, need to have abortion or an early termination. That does not change the prognosis. There are 4 genotypes of hepatitis E. In Pakistan, we have genotype 1. There is a vaccine available for hepatitis E in Pakistan. It's a Chinese vaccine, but very few people will get it. This is the organ under consideration. Liver is unique in many ways. First, it gets blood flow from 2 systems. 75% of it comes from portal vein, and a mere 25% comes from the hepatic artery. And then it is the seat of so many reactions chemical actions that take place. And what we have seen that people, when they develop this permanent or acute viral hepatitis, they are advised meaty cheesing, meatha juice. That's not required. People ask me what is the parhez, and I tell them it's given in our book, holy book. In half an ayat, you have the full hikmah. وَكُلُوا وَاشْرِبُوا وَلَا تُسْرِفُوا. और खाओ और पियो मगर इसराफ न करो, ज़्यादा न करो. सब कुछ खाएं, थोड़ा थोड़ा खाएं. And that is the mantra in diabetes, in heart disease, in whatever disease. There are two types of cells, hepatic parenchymal cell and non-parenchymal cell. Acute liver injury, parenchymal cells are damaged. Non-parenchymal cells are Kupffer cells, stellate cells, and sinusoidal cells. Chronic injury, they are damaged, and they lay down fibrosis, and that leads to nodular regeneration and eventually HCC. What are the mechanisms which cause injury to the liver in acute hepatitis or in chronic hepatitis? The mechanism is simple. There are primarily two mechanisms which cause any death of the cell or damage to the cell. Are you aware of those? First, we have been hearing since morning is inflammation. Whether you're talking about NCD, which is diabetes, or hypertension, or cardiovascular disease, or cancer, or obesity, there is widespread rampant inflammation. Inflammation, ऐसे storm आ गई. And what is the opposite that causes cell death? Apoptosis. वो ऐसे जैसे fall आता है, जैसे खज़ां आ जाती है और पत्ते झड़ जाते हैं. कोई चुपचाप को death हो जाती है cells. And these are the mechanisms which are running side by side. Eventually, the mitochondria is the seat of damage, and it is either the antioxidants, free oxygen radicals, ischemia of the blood flow, which will determine that the organ will either have inflammation or apoptosis, anything and everything that can prevent inflammation or apoptosis can lead to fatality. This is the disease which Professor Javed Akram also referred to in the well-being walk. Metabolic dysfunction associated steatotic liver disease, previously known as NAFLD, non-alcoholic fatty liver disease. Come June 2023, 56 societies sat together and decided to change the nomenclature. It's called metabolic dysfunction associated steatotic liver disease, and we are seeing an increasing number of MASLD patients. When we call it MASLD, when more than 5% hepatocytes have fat in them. The cumulative prevalence of MASLD is rampant in Pakistan, 30 to 53%. MASH is steatohepatitis, which is more aggressive form of MASLD. First there is steatosis, then there is inflammation, and then there is fibrosis, and eventually ending up in HCC, hepatocellular carcinoma. So this is how it progresses, but there are two diseases, rather three, which does not progress like hepatitis C. Hepatitis C progresses very smoothly from inflammation to early fibrosis, late fibrosis, cirrhosis, and cancer. But three diseases, hemochromatosis, follow the same pathway. Metabolic disorders, autoimmune hepatitis, all follow the same pathway. But hepatitis B, alcohol-induced liver disease, and metabolic dysfunction associated steatotic liver disease may not follow the same pathway, and slight inflammation without leading on to cirrhosis can end up with HCC. In USA, in year 2023, MASLD has become number one cause of liver transplant. It has surpassed hepatitis C or B. Pakistan is still hepatitis C is rampant. Pakistan, an article appeared in Lancet in 1996, and it said Pakistan a cirrhotic state. Cirrhosis is very common. 41 to 50% people with cirrhosis will have hepatitis C. 10 to 30% will have hepatitis B. And I have been seeing lots of cases, sir, who have chronic hepatitis E, but more common than hepatitis B, but less common than C is MASH, metabolic associated steatohepatitis, as cause of liver cirrhosis. Pakistan एक signatory है to a treaty of WHO by which hepatitis C has to be eradicated by 2030, but we are nowhere near target. उसके मुताबिक अगर हम आज शुरू करें तो we should treat 1.7 million patients every year for 6 years to reach eradication. Egypt has done that. उनकी prevalence हमसे भी ज़्यादा थी. Their prevalence was 12%, and our prevalence now is 4.3 or 4.5%. Lekin that means 10 million cases. Population is 240 million. So we are nowhere near that. So when that is not foreseeable, what do we have to protect the liver? And this the message has brought to the top. It is not on the top yet in Pakistan, but in the world it is the top. Their world population, about 30% has masculinity, which is 2400 million of 8 billion. And then we have HCV, which is only 100 million. Hepatitis B virus is about 300 million. Alcohol, drugs and toxins, autoimmune metabolic disorders. So what is the first thing when a person comes with liver disease? The first thing is a therapeutic lifestyle change, and you have to do patient-centric, patient-partnered approach. Yesterday there was an amazing talk by John Colby, who is President of International Society of General Medicine, and he made a talk on difficult to treat and mild asthma. And I asked him at the end of his talk, what is the average time you spend with your first-time patient who has come in with mild asthma? And he said, it takes me 40 minutes. And Lord, that is what the patient needs. Patient-centric, patient-partnered approach. और हमने भी यही कहा है, इस कॉन्फ्रेंस की थीम है, evidence-based, patient-centric medicine. Professor Aziz from Swat made an excellent presentation, and he said, only evidence-based is not possible, is not the right choice. You need to have patient-partnered approach. It requires time, it requires effort, it causes personalized care, and that is the requirement. In the meanwhile, when we do not have a medicine, recently a medicine has been approved in March 2024, resmetirom. उससे पहले there was no approved medicine for masculinity. अभी मार्च में हुई है resmetirom, which is a thyroid hormone receptor agonist. So, and it's very, very expensive. 1 month dose costs about $4,600 US. $4,600 US. और ये तकरीबन 12-13 लाख रुपए होता है एक महीने की दवाई. So what do we have? We have a product which can protect the seat of injury. चाहे वो apoptosis हो, चाहे वो inflammation हो. It protects the mitochondria. Apoptosis is caspase dependent, जैसे मैंने कहा है वो कज़ा आ जाती है, and ATP depletion leads to necrosis. ये storm आ जाता है. And what is that product? It is called LIV52. It's a product which is developed in India, neighboring country, and being marketed in Pakistan. It has 4 important ingredients, and Capillus spinosa, Terminalia arjuna, Sycorium intybus, which is Kasmi, and Solanum nigrum, which is Kali Pati also. So nigrum is black. So what action do they have? Capillus spinosa, there are many studies, there is evidence, क्योंकि आजकल ज़माने evidence-based medicine. So I am going to share with you the evidence that Capillus spinosa is antioxidant. It scavenges the free radicals from the mitochondria, and it inhibits lipid peroxidation, which is a cause of disease. And psychorium increases glutathione, and glutathione is anti-inflammatory. Solanum nigrum, it preserves the structural integrity of cell memory, and it helps hepatocellular regeneration. Arjuna जो है, it's a native plant and we see it in Lahore and all parts of Pakistan. It decreases cholesterol level and that is also antioxidant and anti-inflammatory. So role of, now look at one ingredient at a time. This is World Journal of Gastroenterology. In conclusion, this article said that Psychorium inhibits cascine has hepatoprotective effect, and that is due to enhancement of antioxidant enzymes and reduction in mineraloaldehyde. And this is a study, a meta-analysis of 3 clinical trials, 50 phase 3 clinical trials, 50 with 4,490 patients, showing that LIF52DS, if you give it once, twice a day, significantly reduces bilirubin, ALT, and AST. And look at the data here, which I'm going to share with you. LIF52 significantly decreased triacylglycerol content, and that leads to reduction in inflammation. It increases insulin-mediated glucose uptake by threefold. Threefold means 300%. And decrease significantly lipid peroxidation and increase albumin content, and albumin is very significant. Now come to other effects on appetite. It enhances appetite, it improves food intake, and in children it can lead to enhanced height and weight, and it also improves serum albumin. It's available widely, 65 countries. There is a clinical experience of about 70 years, and there are more than 250 studies, and they have consistently shown that it is hepatoprotective. Now look at another part, Capillus spinosa. It protects liver injury with antioxidant capacity and free radical scavenging and inhibition of lipid peroxidation. Or Psychorium inhibits, again, cascine in Urdu, is an antioxidant and hepatoprotective agent. So in cirrhosis, this was a long-term study, 6 months. No patient had severe ascites, no patient developed child Q class C. At the beginning, ALT level was 89, and then it was average, reduced by more than half, and AST similarly reduced by about 40%. Efficacy in liver cirrhosis, this is Elsevier publication, and it shows that there is improvement both symptomatic and biochemical and based on the scan. Total number of papers with LIF52 are 281, clinical papers 185, experimental papers 96. And just look at the comparison, because we have to compare horses with horses. LIF52 with cerebrine and amino acids, and LIF52 has hepatoprotective, anti-inflammatory, liver regenerative, lipid peroxidation inhibition, and cytochrome P450 maintenance. Achillea millefolium is another product which is part of LIF52. It is a chlorinating agent. Best chlorinating agent क्या है? Ursodeoxycholic acid. It promotes bile acid secretion, and this promotes bile acid secretion. Bile is strongly inflammatory. It's available as a syrup, an ordinary tablet, and a double strength tablet. This is how it looks like in the market. We have the best of the best come to you from all over the world. सोमिया इतनी सख्त है, वो हमारी जो चेयरपर्सन है साइंटिफिक कमेटी की, उसने पाबंदी लगा दी कि आप लोग स्पीच नहीं दे सकते, टॉक नहीं दे सकते. वो तो हमारा जो है लेक्चर देने का जो मुआवजा है वो इतना कम है कि ये इंडस्ट्रियल सिंपोजियम में फिर मुझे और अजीजुर रहमान को और हम जैसे लोगों को मौका मिला. वरना कॉन्फ्रेंस की तरफ से हमें कोई टॉक देने की इजाजत नहीं थी, सिर्फ फॉरेन स्पीकर्स या रिसर्च वालों को इजाजत दी गई। थैंक यू वेरी मच।
The topic I am going to talk about is severe community-acquired pneumonia in low and middle income countries. And why I chose the topic, it would just be highlighted as why it's important for us. Although it's an industrial symposium sponsored by Abbott, but my pockets are empty. So I have not received no honorarium or any support from them. Now, community-acquired pneumonia remains a leading cause of hospitalization and mortality and a lot of health cost. It's 8th leading cause of death and first among the infectious causes of death. The early diagnosis and decision where the patient should be looked after and appropriate level of care, that makes a lot of difference and improving the outcomes. Last 2 years have been, our main focus has been COVID or so, right? And if you look at the front row in 2019, pneumonia remained the towering cause of death and mortality. In 2021 and 22, the main culprit had been COVID, but come 23 and we again are having. Maybe we are more focused and more of the people of pneumonia died of COVID. So that's why probably we had a lower mortality, but that's what the figure says. But returning to severe community-acquired pneumonia, it's a life-threatening form of community-acquired pneumonia which requires an intensive care setup or admission to hospital, and it does have a high mortality. The overall world-over mortality as a result of severe community-acquired pneumonia is about 23%. But the mortality rate in lower and middle income countries like us is as high as 40%. And compared to 10% in the advanced countries, 40% and overall it turns out to be 24%. And there is substantial burden of disease is on the productive years. We have more of either children or elderly dying of this disease in the advanced world, but in the middle, low middle, the people of middle age group, of earning age group, they are, and the working age group, they are being killed. This tells us this: the darker the area is, higher the mortality is. So most of the mortality in adults is in the southern part of the hemisphere and more in the what we call it, all the low and middle income countries. And when it comes down to the children, it's further, Pakistan still has a quite darker representation in that. This is 2019, as I said, till 2019 we are focusing on data, but then COVID came and all our energies or our things were moved towards COVID and we lost. So the last data we had is it led down to 2.5 million deaths all over. Majority of these deaths still occur in pediatric age group under the age of 5 years. And it's said that every 30 seconds a child dies of pneumonia. Coming on to the other side, of the larger side of the adults, again the children, and then come the adults, and then the elderly population. So the two extremes, one is the very small children, and then the elderly population that suffers from it. Over the last 20 years, if you see on the left side of the screen, there has been a substantial decrease in mortality as related to the children. But if you look onto the upper line, it says there that the mortality has reduced, but it's still high. And if you go onto the left side, look at the proportion of deaths in the 90s, majority were the children, and the children mortality has substantially decreased thanks to vaccination which is practiced now, and the mortality in the adult or elderly population has decreased but still is quite high. Now, what is distinctive characteristic of community-acquired pneumonia in low and middle income countries like us? One, resource limitation. We have poor resources because, as I said, this type of pneumonia has to be or requires the management in a high intensive care setup, though that most of the nations can't afford on a mass scale. Malnutrition and poor sanitation contributes to the severity of pneumonia, and of course limited access to the health care. And the severity assessment tools, as we know, the curve 65 or pneumonia severity index, they have been designed for Western population, or so whether they are rightly applied for our population as well or not, that needs to be looked into or questioned. This is one of Pakistani studies. The contributory factor in an elderly patient and risk factors for pneumonia, still look at it. This particular matter, pollution remains the top, smoking on number 2, no access to hand washing facility. That is again one of the contributory factors for propagation, prevalent, and then of course we still have a lot of second-hand smoke, because we have not yet developed culture of smoking in cabins or no smoking in public places, so that remains the contributory factor. When it comes down to initial assessment of the community-acquired pneumonia, first we have to confirm the diagnosis, whether it is pneumonia or is bronchitis or whatever. Then we have to assess the severity, and then we have to identify the carrier pathogen. As regards the diagnosis, when the physical signs such as dullness, percussion, bronchial rest sounds, tracheal breathing, they are helpful but not very specific. Okay. When the gold standard still called as chest X-ray, PA and letter 2 have an inconsistent inter-observer agreement but remains an indispensable modality for diagnosing community-acquired pneumonia owing to its cost effective. Right? Now, the CT scan, fortunately again, COVID made us rely on CT scan more and more, HRCT, and fortunately its availability in countries like us also improved. Now we have more centers doing it. So it demonstrated promising outcomes in the diagnosis and resulting in more tailored patient care. But this modality, thoracic ultrasound, point-of-care ultrasound, we have so much improvement in ultrasound machines and all that, that this is becoming more and more of a tool to diagnose pneumonias in the emergency rooms, and of course with time. So in resource limited countries, point-of-care diagnosis, it probably would surpass chest X-rays and HRCT in an initial diagnosis. The next, after making the diagnosis or confirming making it a physical diagnosis, the community-acquired pneumonia, we are all familiar with the severity index. We divide them into, either we use a curve 65 scoring or pneumonia severity index. Both have some similarities, but curve 65 is relatively easier to use and does not require much of investigation. I will just compare them. So divide them into a low risk patient, and the curve score is between 0 to 1. They can be managed as outpatient, and of course monotherapy as antibiotic is recommended. Those who are at moderate risk, they may require an inpatient care, but they do not require an ICU care. For them, the microbiological diagnosis has to be made, and the choice of antibiotic has to be according to the either on empirical basis, we will be discussing in a moment, or maybe based on culture. But still, 5 or 4 or 5 days it takes to the culture reports to come. We still have to make an empirical diagnosis. But the high risk patient, of course, they would require an inpatient care, in an intensive care. They would require a microbiological diagnosis, and of course, we have to rely on combination antibiotics rather than single antibiotic. That's what we'll be talking about. But so, as I said, pneumonia severity index is a rather long list of things which we probably low middle income countries cannot afford in the emergency room or in an outpatient. And again, the utility is again rather a bit difficult as compared to the simple curve scoring, or I'll be talking another simple tool for use in our part. This American Thoracic Society criteria for diagnosing or defining severe community-acquired pneumonia is based on major and minor criteria. So you have to have either two major criteria. One of the two major criteria, either your patient with pneumonia is in shock or is in respiratory failure or impending respiratory failure. That's only one of them is okay. But out of the minor criteria, you have to have three of these, and this one major or three minor of the listed say characteristics makes the diagnosis of severe community-acquired pneumonia. The next is, after you have made the decision that the patient has pneumonia and patient has pneumonia of minor, moderate or severe intensity, and you have decided the care either as an outpatient or to be admitted, or the patient goes to the intensive care, then is what is causing it. Majority of severe anemia, the community-acquired pneumonia still is staphylococcal pneumonia. The next on the list is methicillin, this Pseudomonas, and 14% have this methicillin resistance or MRSA. I will be talking that the casual pathogen, the common one are strep pneumoniae, Enterobacteriaceae, Mycoplasma, and then there are principal say culprits in community-acquired pneumonia. But viral infections, influenza, rhinovirus, SARS, CoV-2, they also come as pneumonia and as a community-acquired pneumonia. And of course, SARS-CoV vaccination, the mass scale which had taken place during the COVID has probably given us some protection against that, but that does not mean that it is gone or it is not to be considered. Another issue in lower and middle income countries is that we still have a lot of TB. And TB either as a on top of an underlying infection or as a still a primary cause has to be distinguished in a patient with who are either non-responded to your common treatment or who are presenting as a CF. Right? And add to it, of course, this is frequent cause of community pneumonia in high burden settings, particularly in children in South Asia, where we are living, and in Sub-Saharan Africa. And finally, in Sub-Saharan Africa, most of them fall in the low and middle income countries. This HIV remains an issue as a complicating factor or as having some atypical organism being responsible for causing the pneumonia. There is an acronym by the name of PES, and PES stands for Pseudomonas aeruginosa, extended spectrum beta-lactamase enterobacteriaceae, and methicillin-resistant Staph aureus. And this is, as I said, the majority of the pneumonia still is streptococcal pneumonia, right? But these 3 to 4 organisms make it more likely that this group of pathogen will be responsible for severe community-acquired pneumonia requiring care. These are some predictions which you can make on that these are the type of people, they constitute a population which are at high risk of developing or having severe community-acquired pneumonia, whether those who have been recently hospitalized, those who have been nursing home residents, or patient on hemodialysis, those who are admitted in ICU, or history of prior antibiotic use in previous 90 days. These populations are more at risk of developing a severe form of community-acquired pneumonia. So, having said that you have a common pathogens, gram stain pe pata chal jayenge. We still have to rule out tuberculosis in our population. We do have to consider viral etiology of pneumonias, influenza and all that. And we have to have just again looking after that the patient may not have harboring this HIV. So sputum, gram stain, blood culture, urine test for pneumococcal legionella stains, on admission would be our result. Sputum this AFT staining or ZM staining probably would not give the good answer. Gene expert is an easier tool, readily available, and of course would be helpful in excluding, not only excluding this tuberculosis, but also probably telling us about the refractory resistance and drug resistance. So in low ambient with high prevalence burden of this HIV, other molecular tools may have to be applied to make a diagnosis. Diagnostic testing, this multiplex nasopharyngeal swab, it is available in Pakistan, costs around 3,000 rupees. Nasal swab, I just said, we were doing it for COVID, and it picks up 3 organisms. It picks up simultaneously influenza A, B, SARS, COVID, and it's a good tool for an initial assessment when patient with severe pneumonias or presenting in, say, ER rooms. Molecular PCR platforms, of course, they mentioned in the Western literature, are expensive, not readily available with us. The rapid performance PCR platforms shorten the time period because time is critical, because these patients may have 48 hours to 72 hours to probably make a quick decision about the right antibiotic and whether they need to be ventilated or whether they need to be put on high flow oxygen or not. There are some biomarkers which help you to differentiate between bacterial or viral, and procalcitonin is again very readily available, and it totally guides us about that the infection is bacterial, but it also helps us for how long we have to use the antibiotic, because serial at procalcitonin level will help in deciding that if it is falling, we can stop the antibiotic at 5 days, and if it not, we may have to continue further. So initial procalcitonin on admission can be helpful in deciding site of care and of course need of intensification. Similarly, CRP, cut-off value of 100 has a 91% of specificity in predicting the patient having pneumonia. Next comes this pharmacological treatment of severe community-acquired pneumonias. How it is different in lower and middle income countries. In our poor settings, the basic resuscitation is often difficult. Oxygen provision at all levels, at the community level, on a smaller hospital or basic health unit is lacking. There is low availability of ventilators. There is increased antibiotic resistance with limited development of new drugs. And of course, given the link between the cardiovascular morbidity, mortality and pneumonia, the overall mortality combined together escalates. The step, as we said, is the most common cause. There are documents or data suggesting that there is reduced in vitro susceptibility to both beta-lactams as well as macrolides, and it's much more common in our part of the world. Klebsiella is a common cause of severe bacteremia. Mycoplasma pneumonia has high prevalence in our part of the world. Legionella is relatively less common as mentioned in the Western literature. So when you come on the treatment, rapid administration of empiric antibiotic combination has been shown to decrease the mortality. We have to cover the common pathogens as we've already shown. Antibiotic coverage should also cover gram-negative. We are talking about severe community-acquired pneumonia, not a pneumonia mild to moderate, which was decided to be mentioned, managed as an outpatient, all right. We are talking about severe community-acquired pneumonia. क्राइटेरिया हमने क्या था कि पेशेंट आपका या तो शॉक में है या पेंडिंग रेस्पिरेटरी फेलियर में है और साथ में निमोनिया कंफर्म है। बैक्टीरियोलॉजी का भी यू आर वेटिंग फॉर, एंड इन दैट केस द कवरेज हैज टू बी broader one to cover all these things. And for COPD patient, of course, E. coli should also be covered. So we have to start with a combination of beta-lactam antibiotics like ceftriaxone and macrolides as compared to beta-lactam monotherapy, which definitely this combination therapy improves the outcome. Levofloxacin monotherapy is also encouraged in the severe settings if the combination therapy cannot be tolerated. Another recommended regime is combination therapy with either cefotaxime, enderabinum, ampicillin, sulbactam combined with either azithromycin or levofloxacin. The duration of treatment, as I said, procalcitonin level would help you in deciding whether you have to continue antibiotic beyond 5 days or it has to be revised. The duration can be extended if patient does. Influenza remains a culprit in patient with pneumonias, and whether it is an influenza or viral pneumonia or for the complication. So some authorities do suggest that adding oseltamivir or zanamivir may also reduce or decrease the mortality till you have availability of this, and particularly in area where influenza is more common and is more prevalent. A beta-lactam macrolide combination may lead to better outcomes. The benefit of macrolides may not be related not only to their antibacterial effect but more to their anti-inflammatory effect. So whether your patient shows sensitivity to macrolide or not, still their use is recommended. This is, as I said, the initial tool we mentioned about the pneumonia severity index was rather difficult to have all those tests done. So if your patient is less than 40 or 65, you score accordingly. If score is less than 1, you just use empiric therapy. If it is high risk, you decide on to take the patient to ICU and select as antibiotic as we mentioned. Non-flow, non-invasive, this is another tool. So oxygen helmet कहते हैं. So this is another tool. High flow oxygen administration definitely improves mortality. Steroids. We are quite fond of using steroid. The only two indication of pneumonia, if your patient is presenting with pneumonia and septic shock, their use is recommended, and of course it has to be given for 48 to 24 to 48 hours. There are some new drugs coming in pipeline, levolamide, diloxapen, amlodipine. We have run that, of course, it would take reaching the lower and middle income countries. It may take another decade, and when they come out, they may be out of pocket range from our part. And vaccination, of course, remains good, particularly in the high-risk populations, that they should be vaccinated so they don't get this severe form pneumonia. This, in summary, there is a lack of high-quality randomized controlled trials in low and middle-income countries to determine the optimal antibiotic therapy. So we remain on to this, probably say combination therapy. Observational studies support the use of combination antibiotic therapy with a beta-lactam and macrolide. In our part of the world, inclusion of macrolide antibiotic has been observed to help in atypical pneumonia, severe pneumococcal pneumonia, that is that macrolide resistant pathogen through their anti-inflammatory effect. The role of adjunct immunotherapy remains undefined. So there is dire need for improved therapies as an outcome of severe pneumonia. In last decade, mortality has not, as I have shown, not made much difference in particularly the adult population. These are few of the references from where this the presentation has been made, and then these are the pillars. So for pneumonia, you have a thorough microbiology, you have to assess the severity, select an antibiotic, best choice would be beta-lactam plus macrolide or beta-lactam plus quinolone, and of course duration of therapy has to be minimum of 5 days, and depending upon procalcitonin level, it may be extended up to, and of course the majority of these patients may require an assisted ventilatory support, high oxygen therapy and all that. So that's all what I have to say about the challenges for managing, say, this severe community acquired pneumonias in our part of the world. Thank you for the patience.